Assalamu alaikum. Welcome everyone. Today I would like to welcome Dr. Riyam Rashid, consultant ophthalmologist from Iraq, working in United Emirates. And today she will talk about approach to patient with diplopia. And it's our first lecture for international speakers. And inshallah, it will be invitation for any international speaker to give lectures here in our group, in pediatric ophthalmologist and neuro-ophthalmologist. Please, Dr. Riyam, can you please start your lecture? And you are more than welcome in our group.
Thank you so much, Dr. Abdurrahman, for the nice introduction. And thank you for inviting me to be honored and to present this lecture. And it's actually my pleasure. I'm Dr. Riyam Rashid from Iraq, working in the United Arab Emirates and Sheikh Khalifa hospitals as a consultant ophthalmologist with a special interest in pediatric and in neuro-ophthalmology. So let's talk in general about approach to a patient with diplopia, but later on we will go, inshallah, to expand our approach to diplopia in the next few lectures that are upcoming. Maybe we will talk specifically about ocular motor nerve palsies in the upcoming lectures, or systemic causes of diplopia later on. So there is no financial interest in any of the mentioned procedures or tests in the lecture. As any patient coming to our clinic, we have to approach him by history, examination, and later on investigation. And examination, as always, we are doing in our clinic, could be firstly systemic, then ocular examination. Regarding the history of all of the following mentioned questions are very important, and they're actually crucial in our approach to a patient with diplopia. But the most important one, which gives us a hint about whether the diplopia is purely ocular or related to other neurological or systemic features, as whether this diplopia can disappear by occluding either eyes or not. Is the diplopia monocular or binocular? This could be decided only when the patient mentioned that if he or she closes one of his eyes, the diplopia disappear. But we have to confirm that this one eye could be the right or the left. Disappearance of diplopia is consistent whether he closes the right or closes the left. If he mentioned that the diplopia disappear when he closes one of them specifically, like only the right, but doesn't disappear while the left is closed, this is not binocular diplopia. He should accurately mention that either eyes can be closed to get the diplopia relieved. And this features the diplopia is binocular. And if the diplopia is monocular, which cannot be disappeared by closing either eyes, we are purely ocular features. We have to go pure systematic ocular examination. We have to find the cause of diplopia through the eye, mainly. If it's binocular, which means this can be relieved by or disappeared by closing either eyes, we have to look for the neurological or systemic cause of diplopia. So we have systemic workup furthermore. We have to ask about the onset and progression of the symptoms or the signs. Any associated symptoms or signs with the diplopia, like ptosis, pain, headache, muscle weakness. Another important question is alignment of the images and the direction that results in the more separation. Like if the patient mentioned that his diplopia is more like in the right direction, we have to check exactly which muscle can be involved in the right or in the left direction, which muscle. If the diplopia is more in near position or for far, we have to look carefully which muscle is really involved in this diplopia, which gives us a hint about the cause or the accurate nerve that is involved in the possible involvement in the cause of diplopia. And furthermore, we have to ask about exacerbating and relieving factors, whether the diplopia relieved by rest, whether the diplopia released by ice packs, whether the diplopia appearing more with at the end of the day, whether the diplopia can be relieved by taking specific medication or not. Any associated symptoms, as I mentioned, like ptosis, muscle weakness, systemic features, dysphagia, which means difficulty in swallowing, any past medical or surgical history, like any history of childhood strabismus if the patient is adult, any history of trauma is very important, any history of closed head injury, very important, any family history of myasthenia gravis, any family history of other autoimmune disease or inflammatory disease like multiple sclerosis. These are also important and crucial questions in our history. Starting with our systemic or general examination, we have to look carefully for the patient. As we shifted from the history to exam, we have, while taking the history, we can do this step. Look at the patient. If the patient has any abnormal head posture, his face has been tilted, his face has been turned, or his head has been tilted, any chin up or chin down position. We can go through these abnormal head posture briefly, like if the face is turned to one of the direction, like to the right or the left direction, we have to look carefully in the horizontal cause of this face turn. Usually horizontal, one of the horizontal muscle, one or more of the horizontal muscles are involved in this. If the head is tilted, most likely we want to look in the oblique muscles. One of the oblique muscles is involved in this etiology. If the chin is up or down, we have to look in the lid or globe position and any vertical deviation. Apart from abnormal head posture, going through our external examination, facial asymmetry can give an idea about long-standing fourth nerve palsy, long-standing congenital strabismus, lid position, whether ptosis or retraction, both of them are important in our etiology. Any frontalis muscle overaction, any abnormalities in the face, like facial deviation, facial sensation. These are very important association with double vision, which has been involved in a neurological etiology. Exophthalmometry can be performed if there is any suspicion of exophthalmos or enophthalmos. As we mentioned, that one of the most important questions that we ask the patient about is history of trauma. So enophthalmos, usually one of the findings that we can find an orbital floor fracture, blowout fractures. They can present with mild enophthalmos and history of like car traffic accident or closed head injury with a blowout fracture, which can pass unnoticed by the history. The patient will not mention that he got this trauma, and his enophthalmos is not really significant, not cosmetically disfiguring him or her. So it might be overlooked very easily. So we have to look carefully for the globe position, and we can relate if there is any history of a trauma later. We can relate with it. This is one example of bilateral asymmetrical ptosis in a patient with ocular myasthenia gravis. We can notice in the picture that there is a frontalis overaction. There is elevation. He's trying to elevate his lids by using his frontalis muscle. So we can notice very clearly that there is a frontalis muscle overaction over both lids. The patient has ptosis as well on the right eye and even in the left eye, but it is severe ptosis in the right or complete ptosis in the right. Passing through the systemic examination can be more expandable, actually, according to the relevant features that we got through the history and examination. Like if we got one feature, we have to dig in the same feature. We can go through neurological exam further more and more with help of a neurologist as well. But Skipping this part specifically per case, which is case specific, we have to go through our ophthalmologic examination. As we do in our clinic on daily basis, we start with visual acuity, whether refraction, whether the diplopia can be relieved with pinhole or not, which gives an idea that the diplopia is more likely to be monocular diplopia that's related to the media opacities, for example, like cortical cataracts, like corneal opacity, even vitreous opacity, sometimes even posterior vitreous detachment can cause monocular diplopia. Very interesting to mention that there is bilateral monocular diplopia, can be presented in a patient with cerebral lesion, like cerebral cortex infarction. What we call it cerebral polyopia. The patient has monocular diplopia in each eye, which can be relieved by bilateral pinhole examination. This is very interesting case and really very rare. It has been documented once, I think reported once in the literatures. Complete orthoptic examination that we do for any patient with a neurological or subsequent finding using patching, full motility test, cover and cover, saccade and pursuit. Pupillary examination is very important part of the examination. We have to look carefully for the pupil size, reaction, and complete slit lamp examination. We might perform some specific tests according to the finding of the done examination. Like if you find that fatigability is positive, we will go through ISPAC test. If there is any possibility that this diplopia due to restrictive cause, we have to do force reduction test or IOP differential test. Force reduction test can be done under topical anesthesia in outpatient clinic in adults, but in children it's really uncomfortable. We cannot do it without full anesthesia, general anesthesia. Can help to differentiate paralytic from restrictive causes of diplopia, or sometimes in some cases combined. Very important not to overlook through these points. We have to examine the fellow travelers, what we call fellow travelers, which are the parts that are related to the diplopia in very crucial way. We will not miss them. We should not miss them, actually. The pupil examination, as we mentioned, the other cranial nerves, the facial sensation, and the lids and the globe position. We have to look carefully for this association. Going through etiological classification of diplopia, whether the diplopia is monocular or binocular, we said that we will go through occlusion of either eyes. If the diplopia disappears by occlusion of either eyes, it's binocular. If it doesn't disappear by occlusion of either eyes, it's monocular. The binocular diplopia can be comitant or incomitant. How we can differentiate between these two types? The monocular diplopia can be repetitive diplopia or ghosting. The ghosting usually can relieved or resolved by pinhole examination. If the ghosting diplopia cannot be resolved by pinhole examination, it's most likely due to retinal lesion or macular lesion. The binocular diplopia can be comitant or incomitant. The incomitant can be differentiated into paralytic and restrictive by using force reduction test, as we mentioned. The comitant cause of binocular diplopia usually due to decompensated phoria or vergence, paresis, or paralysis. There are two types of vergence paralysis, like divergence paralysis and convergence paralysis. Can be presented with binocular diplopia, which is more likely to be comitant. This can be differentiated through the motility test, cover and cover, and patching. Passing through the examination, which includes the systemic and ocular examination, we are heading to the investigations now. What we need to define the cause of diplopia, the possible etiology of diplopia. We might need neuroimaging. We might need to do some blood tests for thyroid function or for myasthenia gravis antibodies. We might do EMG or tensilon tests in advanced cases. And our special investigation that we have to pass through today is his chart or list screen. Both of the tests comes with his charts. The report comes as his charts report. We will explain more about this test because it's really specific to our job. Maybe the other systemic investigations are related to the neurologist more than us. What are the red flags in diplopia? That may we say that these red flags will head us to do neuroimaging as urgent as possible. If we find more than one cranial nerve deficit by examination, whether unilateral or bilateral, if we find any pupillary involvement of any degree, especially if the possible cause is third nerve palsy with the pupillary involvement, we have to go through neuroimaging as soon as possible. If there is any associated neurological symptoms or signs, if it's painful diplopia, in painful diplopia, we have to exclude an old age giant cell arthritis, and in young age, and even in children, demyelination disease should be excluded. Any inflammatory etiology of diplopia like myositis, Tolosa-Hans syndrome, cavernous sinus thrombosis, they should be excluded in painful diplopia. And even ophthalmoplegic migraine can be a cause of painful double vision with unilateral headache. Proptosis can give us a hint that there is retrobulbar, maybe lesion. This lesion can be related to the tumor, compressive sign of tumor, can cause restriction in the movement of the eye and then cause diplopia. Simply proptosis can be due to thyroid disorders as well, which needs CT scan to show the muscles involvement in thyroid disease. Back to the unilateral causes, as we mentioned in the previous slide, that the more than one cranial nerve deficit can be unilateral, bilateral. We're talking now about unilateral causes of multicranial nerve palsies. We have to look for other neurological features of brainstem function. We have to look if there is any association of further cranial nerves due to cavernous sinus thrombosis, as I mentioned. And other unilateral etiology is orbital apex syndrome. Orbital apex syndrome or Tolosa-Hans syndrome can be associated with optic nerve involvement. Bilateral can be infiltrative or Miller-Fisher syndrome. Miller-Fisher syndrome is an ocular variety of Guillain-Barré syndrome, which can be presented to multiple cranial nerve palsies. What are the effects of diplopia on quality of life of the patient? Sometimes diplopia even serious to the degree that can cause the patient to commit suicide. That's why it's very important and crucial to treat diplopia, even temporarily with Botox, with Prism. Relief diplopia gives the patients an area to just, to implement the cause. You have to take your time to do the investigation. You might relieve the diplopia for a while with a Prism while you are looking for exact reason and further plan of management. So the diplopia can cause functional impact on the patient life, like he cannot work with his double vision, he cannot live his daily activities normally, and can cause psychosocial or psychological impact as well on the patient, as I mentioned. That's why diplopia should be taken seriously, should be treated seriously. The plan of your care, of your management should be taken as soon as possible. Management of diplopia is usually according to the cause. We have to look carefully for the cause and then go through steps of treatment. Paralytic cause of diplopia usually need long time of management. If you identify the cause, you have to go through full neurological assessment and then possibility of the cause to resolve by itself, or we need to do a neurological intervention. If not, if any systemic problem should be corrected, like diabetes, if any possibility of giant cell arthritis should be addressed well by the neurologist, and the treatment should be started immediately. And restrictive diplopia, we have to look for the cause carefully, see whether the thyroid function is really abnormal, need to be treated. If there is any inflammatory parts in causes the diplopia, like any inflammation inside the orbit, should be treated well with anti-inflammatory, sometimes even immune modulatory treatment. That's why the treatment is really cause-directed. We'll go through examples of individual cause of diplopia. This patient with dysthyroid ophthalmopathy show asymmetrical restriction of upgaze and abduction. We will go through the central image. The central image shows the patient having his eye elevated in the right eye, but not elevated in the left. There is restriction in the elevation of the left. The middle upper image, the right eye is really elevated to some degree, while the left is not elevated at all. He's trying to look up, actually, in this image. And the rightmost middle image, the patient is trying to look to the right, but there is no movement, actually, in the right eye. So there is restriction of his abduction as well. In the leftmost image as well, middle image, the patient is trying to look to the left, but there's restriction in abduction of the left eye, which makes the possibility of dysthyroid ophthalmopathy very important, because the patient has really limitation, even if it's asymmetrical, it's not really clear, but there is limitation in the upgaze and the abduction. And the patient with thyroid disorder, we will go through CT scan to see the muscle involvement in thyroid ophthalmopathy. And usually we will find in the CT scan that the muscle is affected without involvement of the tendons. This is the typical finding. In the thyroid ophthalmopathy, the typical neuroimaging that we have to go through is CT scan rather than MRI to show the muscle involvement very clearly without involvement of the tendons. As I mentioned, the management of diplopia, sometimes we relieve the diplopia by temporarily by using frontal prism that can give some symptomatic relief in the meantime till we get the implementation of our treatment plan. This patient is also having, most probably he's having dysthyroid ophthalmopathy. We can tell through the bilateral retraction of the upper lid, which is clearly there, and some degree of rhabdosis as well. So he is probably having some double vision. That's why he's wearing frontal prism on his left eye to relieve his diplopia. In the central image of this slide, we have the patient looking straight. He has his eyes really straight as well. There is no abnormalities in the alignment of his eyes. I can tell that he is really straight. But what we can notice as well, that he has very mild enophthalmos in the right eye. The patient, as I remember, is having a history of trauma, head trauma, and he is presenting with right orbital floor blowout fracture, orbital floor fracture. The right eye is relatively enophthalmic, as I mentioned, in the primary position. And he has restriction in the exertion in both attempt elevation and depression of this involved eye, the right eye. So in the leftmost image, he is trying to look up, but he cannot elevate his eye. While in the rightmost image, he's trying to look down and he cannot go really down in the right eye. So there is restriction of both up and down movement of his right eye due to involvement of the incarceration of either the muscle or the fibrous septa. We can't tell by examination that this is the muscle involved or the muscle is not involved. We have to go through the CT scan and see whether the muscle is incarcerated in the blowout fracture or not. In such case, as it's mentioned in this case, taken from Spalton Atlas, that the muscle was not involved, fortunately, but the fibrous septa of the orbital floor was connected into trapped into the fracture. That's why the patient got his vertical diplopia and limitation in movement. In this slide, we can tell that the patient is having ptosis in his left eye. That's why they put the tape, the scotch tape on his left lid to start trying to elevate the lid. And his eye is going also down and out. His left eye, the same eye, has vertical and horizontal deviation due to third nerve palsy. In such case, we have to look carefully for the pupil involvement. If the pupil is really involved or there is any degree of pupillary abnormality, we have to exclude surgical cause of third nerve palsy. We have to look carefully if there's compressive lesion, if there is any history of a trauma-causing hematoma compressing the third nerve, or if there is any mass, a tumor affecting the pupillary nerve fibers causing the pupil to be affected. This is what we call it the surgical third nerve palsy. Heading through other examples of cranial nerve palsies or causes of diplopia. As we mentioned, that it can be neurological causes, as we mentioned, third, fourth, or sixth cranial nerve palsy, or mechanical causes. The mechanical causes can be orbital floor fracture, thyroid ophthalmopathy, as we've seen in the examples mentioned, and can be ocular mechanical causes like the cranial nerve disinnervation syndrome, Duane and Brown syndromes. Which is interesting to mention that the neurological causes of diplopia can appear through the His chart as by proportional spacing of muscle sequelae. It can pass through regular steps of muscle sequelae. While in mechanical causes, the field is usually affected in the His chart with limited degree of muscle sequelae. We cannot tell that there is muscle sequelae in the His chart of mechanical causes of restrictive myopathy, like orbital floor fracture or thyroid eye disease. We'll go through some examples of His chart to differentiate these types. What do we mean by muscle sequelae? I'll take example of our muscle sequelae. Usually there is underaction of the affected muscle. Like for example, in this image, we have underaction of this muscle, the superior rectus muscle. There is usually overaction of its yoke muscle according to Herring's law. Okay. Then there is overaction of its antagonist, which is in this case the inferior rectus. Then disinhibition or secondary disinhibition of the contralateral antagonist, or it's the antagonist of the yoke muscle. In this case is the superior oblique muscle. There is underaction of superior oblique muscle. In neurological or neurogenic superior rectus palsy, the changes will come with time. This is what we call it muscle sequelae. It's coming in sequence. And we can tell that this is coming in sequence by doing frequent His chart to the same patient over time. This is the final appearance of superior rectus palsy over time, coming with superior rectus underaction, inferior oblique overaction, some degree of inferior rectus of the same side overaction, and contralateral superior oblique underaction. What we can see in this slide that the left eye, his chart, is smaller than the right. So it's usually we have to tell that the smaller is usually the abnormal. So the left is most properly the abnormal eye. We have to look for the cause through the left eye. Which muscle is really affected? There is interaction of, as I can tell, all the muscle or the extraocular muscles. Apart from the lateral is overacting. So which one is the abnormal eye? The left, as we mentioned. The small field is the abnormal eye. Which muscle is affected? Now, where is the primary position? The primary position is down and out in the left eye. So the left eye is exotropic, XT, and hypotropic. Okay. So most probably, the third nerve of the left eye is affected. As we mentioned, all of the muscles are affected apart from the lateral rectus, so the superior rectus, the medial, the inferior rectus, and the inferior oblique are all underacting, which makes complete third nerve palsy possible in this eye. Where is the overacting muscles? We have all of the muscles of the right eye, of the contralateral eye, are affected, apart from the medial rectus and inferior rectus. What is the diagnosis then? Left third cranial nerve palsy. This is also going through like it's right, hypotropia, and exotropia. Okay, so the right eye is the abnormal eye because it's a smaller chart, and it's also hypotropic and exotropic, but it's an old third cranial nerve palsy. The primary position is the same, hypo and XT. The diagnosis most properly third nerve palsy. This is a third nerve palsy, but it's really long standing, so you can tell it's the same position, but the overaction is not the same as the first case. What are the root causes of diplopia that we have to not overlook them? We have to think about them when we didn't get the real cause of diplopia. Any history of hemorrhage, like postpartum hemorrhage in adult female, which makes the possibility of pituitary apoplexy, especially in female with clear history of pituitary adenoma, even by accidentally finding this pituitary adenoma. Pituitary apoplexy can cause severe ischemia and the surrounding cranial nerve near the pituitary. Can come with similar presentation to cavernous sinus lesion because all of the cranial nerves passing through the cavernous sinus are very close to the pituitary, especially if the pituitary having adenoma, develop some degree of hemorrhage causing ischemia in this cranial nerve and affecting them. Large pituitary tumor also can come with double vision in case of severe bitemporal or complete bitemporal hemianopia, can cause hemifield slip or hemifield slide, what we call it. The patient can develop double vision in certain situation when he is trying to look in the far. When his two hemifields are sliding over each other's, causing hemifield slide or hemifield slip, the patient can develop temporary diplopia. Paraneoplastic syndrome can come as double vision or some cranial nerve palsies. Carotid cavernous fistula as well, history of a trauma or history of hypertension in old age patient presenting with usually multiple cranial nerve palsy, but can present with single cranial nerve palsy with some finding like corkscrew vessels in the conjunctiva, some degree of proptosis or hemorrhagic chemosis, should give the possibility of carotid cavernous fistula. Neuroimaging with venography are very crucial in this point. And some psychological or psychogenic causes of diplopia are still there. The patient can have causes, real cause of diplopia, organic cause of diplopia. Still, if we didn't find any organic cause, we might consult the psychiatrist for any psychiatrist illness that the patient's having, maybe, or even neurological causes that we cannot tell, like skew deviation or cerebral polyopia, should be excluded with help of a neurologist or psychiatrist. These are our references for this lecture, and thank you for listening to me. I'm ready for any question.
Thank you so much, Dr. Riyam. Actually, it's very interesting, nice, beautiful lectures with a lot of information, actually.
Thank you.
Actually, I learned a lot from you. We have 10 to 15 minutes, inshallah, for questions. So please, anyone have any question, you can write in chat or you can just open your microphone. Okay, it's a good sign that the lecture is very clear.
So
Okay.
maybe the lecture is very clear or very not clear.
Okay, actually, I have some questions.
I got one is thanking me. Thank you so much. Thank you.
Yes. Okay, let me ask you, Dr. Riyam, so there is no one will ask. So there is Dr. Sarah, she left her hand. Please, Dr. Sarah, you can ask. I will let everyone ask before my turn.
السلام عليكم.
وعليكم السلام.
كيفك دكتورة؟ إن شاء الله بخير.
يا هلا سارة.
أهلا وسهلا بك. دكتورة, my question, simple measures deal with diplopia, especially when we are dealing with patient in peripheries. We cannot prism and difficulties, you know. طبعا وياك دكتورة سارة من العراق.
يا هلا بيك دكتورة. شرفت.
أهلا وسهلا بك. لو عيني.
زين. Okay, so you are working in the peripheries and you don't have access to measurement.
Yes.
Okay, simple test for diplopia. Motility is very important. You know, the measurement of degree of sequence in diplopia is not really important to that degree. Your crucial test is a motility, the pupil. You can do it without resources, actually. I didn't even mention that we need to use the prism to measure the degree of diplopia. We can use the prism. Still, we will consider the double vision as any neurological case or any sequence case. We need the prism to measure the degree of maybe of deviation. But the degree of deviation is not the crucial part, actually. We are looking for the cause of deviation. Cause of deviation can be excluded or even can be minimized. The list of causes can be minimized by using your simple test, motility test, your torch. Just examine the pupil, check the motility. You have even use your pen as a target. Check the motility. Look for how many cranial nerve has been involved, how many muscle involved. Is there any possibility of a restriction? It's really paralysis or paresis. Look through the history carefully. Any history of diabetes, any history of pain, any history of surgery, a history of trauma. These are the main signs and symptoms we are looking through to exclude the main causes of double vision. The critical causes, like the patient's very old age. For example, I got a patient who is very old age coming to my clinic. It's really was my case. I got a patient, I think a few months back. She was very old age, coming with pain, and she was diagnosed as diabetic with, I think, 6 nerve palsy. Diabetic with 6 nerve palsy. It was like painful 6 nerve palsy, and she is really uncontrolled diabetes. And they were telling her that you are diabetic, and this 6 nerve palsy is going to be resolved by its own. We don't need to treat cranial nerve palsies in diabetes because usually they are resolved by their own. We are just correcting the systemic cause. We are referring to internal medicine to correct the diabetes, the hyperlipidemia, the hypertension, and we are assuring the patient if he's really in the double vision, we might patch his eye, one of his eyes intermittently to relieve the double vision, or might give him prism in certain cases. Then I just looked through the patient. She was really in pain. She was really in pain, and she was having some reduction in her. She wasn't having any reduction of vision. It was isolated giant cell arthritis. I was like, the patient is really in pain. It was really painful. When I tried to check for the temporal artery pulsation, it was not there. It was not palpable. So I did ESR, very simple. ESR, seroactive protein, liver function test, and complete blood picture. These tests, I think they are available in any, even primary healthcare center. You can do ESR, yes? ESR was very high and comes within 30 minutes. And I referred immediately to the neurology, and they did their part of job. That's it. Okay?
دكتورة العفو frenal prism يعني patient temporary measures to relieve his diplopia.
Yes.
Sometimes patient 6 palsy يعني working وactive يعني
annoying. Working active in the buttocks.
حلو.
Working active young, we might go through buttocks. You know, it works for at least 2 or 3 months at least. It might continue to 6 months, and it's very simple to give him 2 units of buttocks into the muscle. Even you can open the muscle if you are. For me, I'm not, I'm not really professional giving buttocks. We don't have it in governmental facilities, but it's available in private. But if you are not very professional giving buttocks like me, you can just get the muscle and inject, or hold the muscle and inject 2 units, very, very little amount, 2 units of buttocks. Yes. And you can relieve the double vision temporarily, like 2 to 3 months, while treating the cause or while getting the diplopia resolved by its own. If the patient is diabetic, for example, ischemic causes of diplopia that are self-resolving.
Yes.
Yes.
Thank you so much.
You're welcome.
Dr. Riyam, there is some questions actually in the chat.
Yeah, someone is asking me, Dr. Ubaida, can you clear to us about torsional diplopia, vertical, horizontal? Yeah, I was telling about I was talking about the head tilt, face turn, and chin position. Yeah, when I mentioned that it's horizontal, vertical, or torsional, most likely we are not. Usually, cranial nerve palsy are not coming in one direction, apart from lateral rectus. Yeah, apart from lateral rectus is purely horizontal because it's only one horizontal muscle affected. So it's purely horizontal diplopia. The patient can tell you that his double images are getting more separated in certain direction. And for example, in lateral rectus palsy or in 6 cranial nerve palsy, the patient is telling you, he's coming to you with telling that the distance diplopia is much more clear to me. I can see more likely 2 separated images. The distance between the 2 images are really clear to me. I can see really 2 images at distance, or I can see really clear 2 images at the right gaze when the right lateral rectus muscle affected. He is more likely to see the 2 images clearly as 2 really doubled in the right gaze because his lateral rectus muscle is not going to this. So his binocular single vision is really disrupted in this direction, the direction of interacting or non-acting muscles. So this is really horizontal diplopia. If you are telling me whether this diplopia can be clearly horizontal, vertical, or torsional, no, I would tell you no, because it's only horizontal purely in lateral rectus palsy. While when we are talking about, for example, third cranial nerve palsy, as we mentioned in the slides that's showing the his chart, all of the muscles are affected. Some of them are horizontal, like medial rectus is affected. Some of them is vertical, like superior and inferior rectus. Some of them, the inferior oblique, for example, is also supplied by third cranial nerve, so it's torsional. So the diplopia cannot be clearly defined as or labeled as horizontal or vertical diplopia. You can tell that this diplopia is horizontal or vertical from the most affected muscle, but cannot be defined clearly apart from the lateral rectus muscle palsy, which is purely 60 cranial nerve palsy. This is the pure horizontal diplopia, the only pure horizontal diplopia. In decompensated phoria as well, if the sequence is horizontal or in convergence or divergence paralysis, also the patient can present with a purely horizontal diplopia. Vertical diplopia is happening usually post-trauma in a blowout fracture. When there is limitation in the up gaze or down gaze, the patient can tell you like his diplopia is getting more when he's looking up. So he's trying to elevate his chin to avoid looking up. If his diplopia is getting more while he is looking down because his muscle is tethered, not going down, he has limitation more in down gaze. His diplopia is getting exacerbated or more in down gaze. So he's trying to get his chin down to avoid looking down by his eyes, to avoid exacerbation of diplopia. It gives an idea, it gives a hint about the cause of diplopia, but you cannot label or define diplopia really by the direction. The direction gives you hints about the cause, but it's not really defined like vertical is purely vertical. It comes usually mixed. Torsional diplopia is really like complicated cases, like 40 cranial nerve palsy. 40 cranial nerve palsy, the patient has contralateral face down, contralateral head tilt, and chin down position. So it's like having some horizontal parts and have vertical parts as well, and torsional parts as well, because of the primary, secondary, tertiary action of each of oblique muscles. It has like primary and secondary and tertiary action. So some of the action is horizontal, some are vertical, some are torsional. So the patient is having like mixed diplopia. You can define the cause by the type of double vision or direction of the double vision, but you cannot label it as like this is torsional diplopia. There is no pure defined diplopia apart from lateral nerve palsy, the horizontal, purely horizontal cause of double vision. I hope this is clear. Maybe the patient has high astigmatism and tells that he has double vision. Yeah, actually, one of the causes of monocular double vision is uncorrected refractive error, keratoconus as well, high astigmatism, as you mentioned, keratoconus or media opacities. If he has high astigmatism, this should be resolved with pinhole if he doesn't have other causes of double vision. When you try unilateral pinhole, or even bilateral pinhole, if bilateral high astigmatism, the patient could be better, inshallah. So the refractive cause of diplopia, this is usually monocular, and even if bilateral monocular diplopia, this should be corrected by pinhole during the exam. Patient 9-year-old with no history except of no history, I think, of having congenital cataract extraction at year of 4-year-old, and he complained of binocular double vision in near 1 year ago. His glasses are binocular double vision in near. So okay, he is a plus. So he was having congenital cataract, and he's got congenital cataract extraction with or without IOL implantation, because he's plus now. Perhaps he got his IOL implanted, but he is still plus because he has only 2.5 plus, yeah? And his best corrected VA is 6.6. This corrected VA is for far. What about the near vision? And what about the convergence? Maybe he's having convergence insufficiency or convergence paralysis. So if he has the double vision more at near, you have to check for the convergence reflex. His pupil action for near, his ocular motility for near any exotropia for near should be excluded by examination. How can I think about this? I hope this was helpful, that you have to check the convergence, and his near vision as well should be checked. if he is on any near eye, if he got cataract extraction and got IOL implanted, so he's now pseudophakic, and perhaps he needs reading glasses as well, if he has any reading aid or not, and any convergence, insufficiency, convergence, paralysis should be excluded. You mentioned the cause actually. you just wrote it. You said that that he might be getting convergence of yes, most probably.
Okay, I hope it's clear. Anyone have other questions? Okay, I have one question, Dr. Riyam.
Yes.
Just from the his chart, like in this picture, we see here like the constricted of the his chart and how the muscle take the his chart to like outward, downward
the
position. But just from only the his charts, how I can always differentiate it's a paralytic or restrictive from
this is
the
very
his chart.
Yeah. And the restrictive causes of double vision, I hope I have an example I can share with you. The restrictive causes of double vision usually on the his chart appear as compressed from both sides. I will show you one example. I think I have a good example about this in another lecture. I'll share it with you.
Do you want to share it now or later on?
I will just look for it now and
okay.
I will try to share it.
But here, like when I look to this picture, like I see it's compressed also. So I was thinking it's maybe restrictive.
Yeah, I will show you the compressed so you can tell that this is compressed. You will see that the patient is really having compressed.
Okay, I mean here it's not compressed from this direction.
No, this is not compressed because the other eye is overacting. This is underacting because you will see that even in the same eye, if the medial rectus is underacting, the lateral rectus is overacting.
Yes.
So it's not really compressed, yeah?
Yes.
Usually in restrictive causes, like in orbital floor fracture, you will find like up and down, they're both restricted. I will show you this. I got it. I will share my screen.
Make share again, please.
Yeah, I'm trying now. See, this is orbital floor fracture.
Yes.
He has underaction in the superior rectus of the left eye, and there is no contralateral overaction. The inferior rectus should be overacting if it's paralytic, yeah? Let's consider superior rectus palsy, yeah? The ipsilateral antagonist should be overacting, yeah?
Yes, you are right.
To shrink till low. It should be overacting, but it's really underacting as well. So you have underaction in the same muscle and its antagonist as well. And this is against the muscle sequelae.
Okay, now it's very clear after I saw the picture. Yes.
Is not defined here. They are not acting according to shrink till low. So this is mechanical, which means restricted because there is no overaction in the both up and down gaze are affected in such case. And this is an orbital floor fracture, as I remember.
Thank you so much. Now it's very clear for me.
You're welcome.
Okay. So I want to thank you again, Dr. Riyam, for your interesting lecture. Actually, I learned a lot from you. And inshallah, we will have you in another lectures, inshallah, in the future.
Inshallah.
Inshallah.
Thank you so much, everyone.
Okay.
And my pleasure to be here with you.
Thank you so much. So I will close the meeting. Thank you, everyone, for your sharing us today.
Good night.
Inshallah. Good night.